All right, so we're going to pick up where we left off. So far we have done the pituitary, hyper and hypo, and the thyroid, hyper and hypo. So now we're going to go down to the parathyroid. We're going to talk about hypoparathyroidism first. And that is a decreased secretion of the parathyroid. So, again, thanks to Dr. Chastain, we have our nifty little diagrams. And the most common cause for hypoparathyroidism is basically accidental. We accidentally remove the parathyroid during a thyroidectomy, or we radiate the neck or have some kind of neck surgery that ruins the parathyroid glands. Because remember, the parathyroid sits on the thyroid. So we have hypoparathyroid, so decreased PTH. And normally that PTH stimulates the breakdown of bone. So this is going to stop this stimulation of breakdown of bone. So we're not going to break down bone. So when we break down bone, we get more calcium in the blood. But because we're not breaking down bone, we have decreased calcium in the blood. In addition, normally PTH will stimulate the kidneys. So it's not stimulating the kidneys. So the kidneys help reabsorb calcium into the blood. So if the kidneys aren't working, we're not going to reabsorb the calcium back into the blood. So calcium is going to be excreted. And normally the kidneys would excrete phosphate. Since it's not excreting phosphate, we're going to have increased serum phosphate levels. Phosphate binds to calcium. So now there's more phosphate to bind to calcium, which is then going to decrease our serum calcium levels even more. So all of these reasons is going to result in decreased calcium. And then in addition, PTH would normally activate vitamin D, and that normally happens in the kidneys, and vitamin D is needed to absorb calcium in the small intestine. So we don't have activation of vitamin D. So we have all these things contributing to a low calcium. And calcium has two main functions. As you can see here, the functions of calcium are to provide electrical energy for the nervous system and the muscular system, and then also to provide strength for the bone. So if there's decreased calcium, we're not going to have strong bones, right? And if we're affecting the muscular system, we could get tetany, which is the Chavost and Trousseau signs that we see. You can get the tingling of the lips, the fingers, the toes, and they can have dysphagia or laryngeal spasms. So we're worried about a compromised airway. So, breathing, we're worried that their breathing might be compromised. And then the nervous system, because again, calcium helps provide that electrical energy, not just for the muscular system, but for the nervous system. We can get lethargy, anxiety, personality changes. And then obviously if we're not activating vitamin D, we're going to have vitamin D deficiency. So diagnostic labs, we're going to have low PTH, low calcium, increased phosphate levels, right? Treatment, well, we need to give vitamin D supplements because we're not able to. And we need to do calcium supplements. It's as easy as that. The parathyroid's destroyed, so it's not like we can fix that. They're going to continue to have low PTH levels, so they're going to continue to have these low calcium and low vitamin D. So all we can really do is just supplement those two things. All right. Opposite of that is hyperparathyroidism. Okay, so with with hyperparathyroidism, we have increased secretion of the parathyroid hormone, so PTH. So we're going to look at our little diagram again. And again, there's a couple of reasons, different reasons why the parathyroid could be overactive. It could be, the most primary reason is that there's some tumor in the gland. Another reason is that you have some kind of decreased calcium level from a medical condition, like a vitamin D deficiency or malabsorption syndrome. And then a tertiary reason is because you have, we don't know why, but you have increased parathyroid hormone levels, even though they are normal calcium levels. So when we look at it, again, the parathyroid hormone is increased. So if its normal job is to stimulate the breakdown of bone, this is going to be increased, which is then going to cause osteoporosis. It's going to make the bones weak, which can lead to fractures. And it's also going to decrease the amount of calcium in the blood. We could have, again, parathyroid hormone affects the kidneys. So, and normally we reabsorb calcium back into the blood, and it's going to do so even to a greater extent because of the hyper PTH. So we're going to have increased serum calcium levels, which overwhelms the renal tubulars and spills calcium into the urine and causes kidney stones. The kidneys also excrete phosphate. So again, that's going to be accentuated. And so now we have, because we're excreting more phosphate, there's less phosphate in the blood and more phosphate in the urine. So again, that's going to lead to kidney stones, and that's going to lead to renal failure and pancreatitis. So the combination of both those kidney stones is what's going to lead to the renal failure and pancreatitis. Excuse my dog barking in the background. She thinks she's a watchdog even though she weighs like 5 pounds. All right, so in addition, we've got vitamin D that's activated by the parathyroid hormone, and it's going to be even much more activated because, again, that PTH is increased. So we have increased vitamin D, which is going to increase absorption of calcium in the small intestine. So there's going to be more calcium in the blood, and we're at risk for cardiac changes. So hypoparathyroidism, low calcium. Hyperparathyroidism, high calcium. So some of those symptoms of high calcium is muscle fatigue and weakness, decreased appetite, vague abdominal pain. They get constipated, have emotional disorders, shortened attention. And then because of these cardiac changes that we were talking about with the vitamin D, they get dysrhythmias and hypertension. They say they're bones, moans, and stones. So because of all the high calcium and phosphate, they're at high risk for kidney stones. In the high calcium in the serum, in the blood. All right, diagnostically. Obviously, clinical manifestations are going to help trigger us to say, okay, something's off. We need to follow up with more labs. And the labs that we're going to get is obviously PTH is going to be elevated. Calcium is going to be elevated. Phosphorus is going to be low. And calcium greater than 10 is considered high, and phosphorus less than 3. Other labs are going to be affected. The chloride's going to be high, the uric acid, the creatinine. Those are all going to be high because, again, they've got kidney stones, so it's going to affect their kidneys. If it leads to pancreatitis, their amylase will also be elevated. We can get a DEXA scan, and that will show us if there's any bone loss because they're breaking down bone more and they're at risk for osteoporosis and fractures. The DEXA scan will show us that. And then the MRI, CT, ultrasound can show us things like tumors or anything else going on. All right, so treatment. If there is a tumor, we do surgery to remove the tumor. If there's low calcium levels or decreased calcium intake or decreased calcium because of some kind of medical condition, then we can take these calciumometric agents. And basically what they do is they make calcium bind better and increase the sensitivity of calcium to the parathyroid gland. So they kind of make their levels so that it helps detect calcium level more easily so that the PTH doesn't have to go so high. So we're going to monitor, because again, anything we do, if the problem was that we have low calcium and we are giving calcium, one, we've got to monitor for signs and symptoms of hypocalcemia and I'm sorry, I'm confusing. So we give these agents because they've got too much calcium in their blood, right? So the condition is caused, so I apologize if I'm confusing you a little bit. So let me start back again. So the low calcium level is what triggers PTH to be high. That's what triggers the retention of calcium, right? So the body is saying, wait a minute, we don't have enough calcium, so we are going to increase the parathyroid hormone to trigger, the breakdown of bone and the kidneys and vitamin D, and trigger all these things to help hold calcium in our body. So we give these agents, these calciumetric agents, because they bond to calcium, to kind of detect it, get rid of it. So that is what we're doing. So we have to be careful because we're helping get rid of these high calcium levels. So even though low calcium is what causes it, the result, because it's our body's reaction to that low calcium is to increase calcium. But that increased calcium is what's causing all the problems. So we have to decrease the calcium. But because of that, when we decrease calcium, we can cause it to swing opposite direction and go hypocalcemic. So then we're going to have those signs and symptoms that we saw from hypocalcemia, from the hypoparathyroid. So like the tingling of the hands and the feet, those type of things, the tetany. So we're going to teach patients to monitor for that, and that they should have the calcium gluconate on hand to give in an emergent situation. Endocrine is hard because it gets a little confusing because it's all this homeostasis, this balance. It's what's causing the condition, how your body's reacting to it, what medicine do we give them, or what treatment do we give them to fix it so that it's not too much or too little, and then we can swing them in the opposite way. All right, we can also give things like biphosphonates, like Fosmax, and this inhibits the bone breakdown. We want them to ambulate and exercise. We want low weight bearing exercises. We don't want them out there jumping up and down or doing contact sports, but swimming and anything that's going to build muscle mass and strength. We are going to, if they're constipated, we're going to give increased fluids. If they have a low calcium intake, then we're going. Okay, sorry, mass chaos just broke out of my house. So I was talking about, if they have a decreased appetite and, we have low calcium intake, we want some moderate calcium intake. We want to increase it because that's going to tell the body we don't need to, make so much PTH. We might need to give them diuretics. That's going to help increase the excretion of calcium in the urine. We might have to give them oral phosphate because that inhibits the absorption of vitamin D. All right, we kind of already talked about this as a patient advocate. What's your focus? What things are we going to do? And again, it's just, if you can understand what it's supposed to do, then you can figure out if there's an imbalance of too much or too little. That's easier to figure out. So with endocrine, it's really, really important to focus on what's the normal. Like, what's the normal for the pituitary, for the thyroid, for the parathyroid? What does it do? And if I have too much of it or too little of it, how's my body going to respond? Because then that's easy for you to figure out what my interventions are then. All right, so we're going to talk about Cushing's syndrome. And this is caused by an excess of corticosteroids. So let's look at the adrenal cortex in general. So any disorder of the adrenal cortex is caused by an excess of corticosteroids. And corticosteroid refers to any hormone produced by the adrenal cortex. So again, there's kind of three things that are going to affect it. So you'll see my etiology is going to be in 3 different colors. All right, so the most common reason is for the increase or excess of corticosteroids is just basically an overuse of steroids, an intake of glucocorticoids. And these are things like, people who take prednisone for asthma. That's why we try to give inhaled steroids instead of oral steroids. People who take steroids for rheumatoid arthritis, lupus, or any other inflammatory diseases, like after a transplant, they're at increased risk because of overuse of the steroids. The primary glucocorticosteroid or glucocorticoid is cortisol. And we're going to look at that at the next page, but cortisol does a bunch of things in the body, like maintaining blood pressure, cardiovascular function. It helps reduce the immune system's inflammatory response. It balances the effects of insulin, which breaks up glucose for energy. It regulates the metabolism of proteins, carbs, fats. It helps our body respond to stress. So that primary glucocorticoid is cortisol. And again, it's just sometimes we overuse it because of different conditions. Another reason that we tend to have Cushing's syndrome or an excess is because of an ectopic tumor. And it can be a tumor in the pancreas or the lung, and basically that tumor excretes ACTH. So we have an increase in our ACTH. So that increase of ACTH activates the adrenal cortex to go ahead and increase sex hormones, increase melanocorticoids, and increase glucocorticoids. And this is what we truly see as Cushing's syndrome, is this tumor that secretes the ACTH, that activates, all the adrenal cortex to increase all the different, corticosteroids. And then the third etiology would be the adrenal tumor that just kind of sits right there at the adrenal cortex, and that adrenal tumor secretes increased amount of corticosteroids. So again, it's going to increase sex hormones, increase melanocorticoids, and increase glucocorticoids. And what happens is that because, again, it kind of reads like this. If all these are high, it's going to then tell the hypothalamus to tell the pituitary that we don't need as much ACTH because we're already high. So that's why that ACTH is lower. So clinical manifestation. So remember I was talking about all the different things that it does, like blood sugar and suppresses the immune system. This is, more of looking at the clinical manifestations. So when we have stimulation of the adrenal gland from hypersecretion of ACTH by the pituitary, which is the Cushing's part, then we get, an increased amount of estrogen and androgen. So we're going to get, I'm sorry, that looks ghetto. Okay, there you go. And we're going to get an increased amount of secondary sex characteristics. So women are going to get hirsutism, the hair on the face. Mood swings are going to be common, and amenorrhea, because again, these there's an increased amount of estrogen and androgens. We're also going to have an increase in mineral corticoids. So it's going to cause aldosterone kidneys to kind of increase. So we have an increased amount of retained water. So that's going to cause hypertension or lower extremity edema. We're going to have an increased amount of sodium retention. So we're going to get hypernatremic. And we're going to have an increased amount of potassium excreted. So potassium is going to be lost, so we're going to get hypokalemia. Cortisol is going to be increased. So we're going to have increased blood sugars. So that's going to cause increased glucose levels, which is going to cause us to have glucose intolerance and develop type 2 diabetes. It's going to have an increase in metabolism. So we're going to get muscle wasting, which is going to lead to muscle weakness. We're going to get increased gastric secretions, and we're going to have lipidosis. And this is where Cushing's, this is where you get those classic symptoms, weight gain and fat distribution. So they get the buffalo hump. So they, like their spine, just because of the way the fat like accumulates in that area, they get that buffalo hump. They get with it, that moon face, that fullness of the face with the facial plethora. But they have really skinny legs. They get truncal obesity, and they get this purplish red striae, which is depressed below skin surface of the abdomen, the breast, and the buttocks. They get, their immune system is suppressed even more, so they can't really have good wound healing, so they get skin ulcers that don't heal very well. They have their blood pressure, their cardiac function increases, so they get hypertension and heart disease. And their bones are breaking down at even a faster rate, so they're developing osteoporosis and, again, fractures. Diagnostics, obviously, again, H&P, including their mental status because of the moon suites and everything. We're going to have increased plasma cortisol levels that are going to be higher. Their plasma ACTH levels are going to be higher. Especially when we're talking about Cushing's. The DEXA scan, that's going to, it's a DEXA suppression test actually. And what happens is that when we try to suppress it, the ACTH remains high because the tumor is going to continue to secrete. We can get a 24-hour collection for free cortisol. Normal is about 80 to 120. And we can get a CT MRI, and that's going to show us if there's the adrenal or pituitary gland, if there is any tumor. And we can get things like CBC, sodium, potassium, glucose, which is going to show us the hypernatremia and the hypokalemia. We kind of already talked about the clinical manifestations and diagnostics. So let's talk about treatment. So let's look back at overview. And obviously, if it's because of too much steroids, we're going to taper the use. We just can't stop steroids. If we stop them abruptly, then we're going to have bad symptoms. So we're going to go ahead and taper off their steroids. Drug therapy includes Nizoral or Cytogen, and that basically inhibits corticosteroid synthesis. Oftentimes, we have to do surgery to remove the tumor. And with that, or radiate it to make the tumor smaller. Pre-op, we are going to make sure that we correct anything that's abnormal. So those signs and symptoms that we talked about just in the last slide, the hypertension, the hyperglycemia, the hypokalemia, those all need to be corrected prior to surgery. And then it says post-surgery, but also during surgery and post-surgery, they're going to get high doses of IV corticosteroids. I'm sorry, my dog is going crazy right now. So you hear her jingling and my other dog whining. So they're going to get these high doses of IV corticosteroids during surgery and for several days after, because when they're taking out that tumor, hormones are released during the surgery, and it can make the clinical manifestations much worse. So we have to give the corticosteroids to help balance out those symptoms. We have to be very careful about reaction to stressors because so remember that part of the what cortisol does is suppresses the immune system. So we have to be careful because they won't really be able to react to stressors or infection as well. So we need to make sure that we, keep that balanced for them and check for signs and symptoms of infection, balance hormones for them, electrolytes. They may even need, help stabilizing their blood pressure if there's still an issue, watching for hemorrhage, making sure we're giving good fluid balance, all of those things post-op. And then, in general, when looking at the disease with Cushing's syndrome, why they're, in active disease state, obviously we have to minimize stress because stress triggers cortisol, and cortisol is already high. So we don't want to make it any higher because it's going to make all those symptoms worse. And then we need to limit water intake because obviously they're already, because of the aldosterone being retained, they're retaining water already, so we don't want them to retain any more, so we may have to limit the water intake. We need to monitor blood glucose levels because of, their glucose intolerance. They need a high protein diet because of the muscle wasting and weakness. We need to check for signs and symptoms of infection and protect the patient from falls because they're not going to heal as well. They may need some antihypertensive medicines to deal with hypertension. If they've got heart disease, we need to assess for edema, check daily weights. So, I already told you the answer, but what client is at risk for developing Cushing's syndrome? Anemia, asthma because of the steroids, also they have colitis because of the steroids, arthritis because of the steroids, minimal change in nephrotic syndrome. All right, and last but not least is where we have decreased ACTH. So adrenocortical insufficiency. So it's hypofunction of the adrenal cortex. So we were just talking about hyperfunction. Now we're going to talk about hypo. And the most common reason is Addison's disease. So what happens is it's autoimmune, and whether they get, tuberculosis, TB, and it destroys the adrenal, or the adrenal tissue is destroyed by antibodies against the patient's own adrenal cortex, or they develop like a fungal infection or AIDS or cancer, some reason, and the adrenal gland is destroyed, autoimmune. Or it can be, or it says, hypofunction of the adrenal cortex. So everything's down. So with Cushing's, your estrogen, androgens, and your glucocorticoids, which is your cortisol, and your mineralocorticoids are all up. With Addison's, everything is down. So everything's down. So there's decreased aldosterone. So we are no longer retaining water, we're dumping water. We're no longer keeping sodium, we are dumping sodium. So now they get hyponatremic. They're no longer excreting potassium, they're retaining potassium. So we're going to get rid of the excrete. So they're hyperkalemic. So now do you see why it's so important to understand these diagrams? Because if you can brain dump these like 3 or 4 diagrams, it's easy to figure if it's too much or too little. You just draw your little arrows and figure it out. And it's the best way to study. So again, you have to thank Dr. Chastain for making them for you. They have decreased development of secondary sex characteristics. They get irritable, depressed. They have decreased cortisol levels, so they have low blood sugar, so they get hypoglycemic. They have low metabolism, so they get weak, fatigue, weight loss, anorexia. They have a low BMR, basic metabolic rate. Sometimes they develop nausea, vomiting, diarrhea. Again, they have decreased suppression of the immune system, decreased blood pressure, cardiac function, so they develop hypotension. They oftentimes get this skin hyperpigmentation in sun-exposed areas of the body, especially pressure points, joints, like the palmar creases. And they get this bronze skin pigmentation of the nipples, scars, the buccal mucosa. Diagnostics, again, H&P. We're going to check the cortisol level, which is going to be low. We're going to have a low sodium, the low glucose, but high potassium, high BUN. Basically, we're going to do an ACTH simulation test. And when we do that, the cortisol fails to rise. So normally when we stimulate the adrenal gland, it will stimulate the glucocorticoids, including cortisol, to increase. But when we do that, it won't. We're going to see peak T waves on the EKG, secondary to the hyperkalemia. We might get a CT or MRI to see if there's any tumors. And treatment is going to be focused on treating the cause, obviously. So if we know what's causing the autoimmune, but again, if the adrenal cortex, the adrenal gland is destroyed, we can't really. And unfortunately, clinical manifestations don't really become evident until about 90% of the adrenal cortex is destroyed. Therefore, the disease is pretty much advanced by the time we really diagnose it. So the adrenal gland is shot. So it's not like we can fix the problem and the adrenal gland's going to get better. It's shot. So they have to be on daily replacements. So they get on daily mineralocorticoid, and that's done in the morning, and it's called Floranet. They are going to be on daily glucocorticoids, like hydrocortisone, and with that, they get 2/3 of it in the morning and 1/3 in the afternoon. And again, we can't stop it abruptly. When we need to, maybe we need to increase or decrease the dose, we're going to have to taper it. We need to encourage fluid intake because their aldosterone is low and they're spilling water. We need them to have good fluid intake, especially in hot weather. They may need salt additives to replace for the hyponatremia. Again, also, especially when there's excessive heat or humidity. They're super irritable, so they like a quiet environment. We need to relieve them of any anxieties. Because of their low cortisol levels, even in stressful situations, their cortisol won't rise. So when they're in stressful situations, we need to give them doses of cortisol so their body can react to that stressful situation. We're going to monitor their blood glucose level. Because they're weak, assist them in ADLs as necessary. We're going to avoid super strenuous activities. Keep monitoring for infection. They oftentimes have wound healing problems because of the medicines we give them, like the hydrocortisone. And they might need antacids. We worry about an Addison crisis, and that's triggered with anything that causes stress. So infection, surgery, trauma, hemorrhage, psychological stress, anything that stresses them out, or a sudden withdrawal of corticosteroids, or after, adrenal surgery, it can trigger this life-threatening emergency situation. And basically what happens is that all the clinical manifestations are hyper magnified. So their blood pressure drops significantly. Their heart rate increases significantly. They're severely dehydrated, which can lead to total circulatory collapse, shock, They have severe vomiting, diarrhea, which again leads to the circulatory collapse and shock. They've got pain in the abdomen, lower legs, lower back. They're confused. Their glucose drops significantly. They get very hyperkalemic, very hyponatremic. So we need to treat the shock and then administer high doses of hydrocortisone while we're giving them large volumes of normal saline with 5% dextrose. And that dextrose helps manages the glucose, and the normal saline helps kind of, give them back all, because they're just in circulatory collapse. It's important to teach the patients about signs and symptoms of Addison crisis, how to manage their stress, avoiding over-the-counter medicines, and that they need to carry hydrocortisone with them at all times. All right, so we kind of talked about all this, your focus with adrenal dysfunction. And then here's kind of like an overview of, it doesn't include the pituitary. So pituitary, remember, hyperpituitary is too much growth hormone, and they get either really tall or soft tissue swelling. Hypopituitarism is too little growth hormone, and that we treat with somatotropin. Then we look here and it talks about hyperthyroidism. They have Acrobat. You can also think of it like Tigger from Winnie the Pooh, or hypothyroidism, which is like Eeyore. And then we've got, they didn't talk about parathyroid. So hypoparathyroid, too little calcium. Hyperparathyroid, too much calcium. And then talking about Cushing's and Addison's disease. So with Cushing's, we have a stimulation of the ACTH, the adrenal cortex. So everything's kind of elevated, too much of your steroids. And with Addison's, there's too little of your steroids. And again, the endocrine system is all a balance of that homeostasis between too much and too little. And they're supposed to balance each other out. And with any of these diseases, you have one or the other happening. And when we give treatment, we can always swing them in the opposite direction. So keep that in mind when looking at your patient and figuring out what's going on with them. All right. Good luck, and I will see you when I get back from vacation for test 5.